Everybody, and thank you for taking time to join us again this evening with the very lively platform of Federation of Obstetric Gynec Societies, Societies of India, that is Fogsi. So this is yet another episode of something very beautiful that we have started in the month of February, exactly 29th of January when we started this. And with God's blessings, we have been able to do this every day with different chairpersons, bringing different speakers from different avenues, not just the medicine, but achievers from various platforms. And that has made this platform so rich. It was obviously the vision of our Foxy president, Dr. Sunita Tandulwadkar, and who has been present in most of these episodes. So I would want to, first of all, thank our guest speaker for today, Professor Tim Child, to take time and join us. I'm sure the number of audience today would be larger than normal. So I would want to, first of all, take a moment to express thanks to the Foxy platform and to mention that we are so proud of the personal and professional achievements over decades in the form of an excellent reproductive medicine specialist and endoscopist that Dr. Tandulwadkar is, and giving the platform to the chairpersons instead. And I would want to now straight away introduce Dr. Tim Child, who is our guest speaker for today. So, Dr. Child is internationally recognized for his evidence-based approach to fertility care. He is an associate professor of reproductive medicine at the University of Oxford and published over 100 research papers. He also co-founded Oxford's MSc in clinical embryology and contributed to the development of the UK's NICE fertility guidelines, which often are the platform on which other NHS protocols are based. From 2004 to 2023, he served as a medical director of Oxford Fertility and the Fertility Partnership, expanding services across 6 countries. He now sits on the HFEA board and chairs its Scientific and Clinical Advances Advisory Committee, overseeing the IVF add-ons traffic light system. And we all know how important is it when we make our standard operating protocols for our practice. I would want to request Dr. Sunita to welcome the guest speaker and then Dr. Tim Child to say a few words before we begin.
Hi, Anu. Fantastic. You always come out with the brilliant academician, and it's always great to have team personality like you to come on this podcast where Anu will have a dedicated 45 minutes dialogue with you, and I'm sure it will be one of the enriched program of our 365 days. We have 30 committee chairpersons, so 30 people on 30 days, the same day, and whenever there is a 31st in the month, I come with them. So it's always pleasure to have academician like you, which will take not only the academic discussion, but probably Anu will bring out your journey as well, because I know she was your student, your mentor, and it must be a proud moment for her to take your interview. Thank you once again for coming on this platform. Our protocol is I will just, after welcoming you and after listening to you, I will just go to the viewers link and enjoy the dialogue between you.
Thank you, Sunita. Thank you.
So, Dr. Child, would you say a few words to begin with?
Absolutely. So thank you very much for asking me to join your podcast. Sunita, Dr. Sunita, you were quite right. So Anu was sort of a student of mine for a while, and I remember her as being a top grade student. It was a pleasure to have her, to welcome her to Oxford, and she was a credit to Indian obstetricians and gynecologists. So it's really nice, Anu, that you've asked me to come and join you and for you to host this podcast today. So thank you very much.
Thank you.
very much,
Enjoy
Dr.
your evening together, and I'll see you. Bye.
Bye-bye.
Thank you, Dr. Tandulwadkar. So I'll start straight away and with gratitude for you to have taken time to join us today. So, Dr. Child, your journey is remarkable from medical studies at Cambridge to London and through subspecialty training in Oxford and McGill to earning an MD researching oocyte in vitro maturation. How did these formative years shape your approach to reproductive medicine?
Yeah, well, as you said, I did my undergraduate medical degree at the University of Cambridge, and Oxford and Cambridge have always had a very, very science-based medical school. So it was our first 3 years, our lectures were shared with the people doing physiology and biochemistry degrees. So it was very, very basic science. So I think from that, I learned a love of basic science. Obviously, not such a love that I wanted to leave medicine and become a pure basic scientist, but I gained a liking of the laboratory science side of things. From there, I then went down to the University of London to complete the next 3 years, the clinical part of my training, and that was in the East End of London, at the Royal London Hospital, which was quite well. The East End of London is a deprived area, a deprived part of London, and so there I just saw incredible pathology, and I really learned my love of hands-on treating of patients. I then came to Oxford for my obs and gynae rotation training, my SHO and registrar jobs. And it was there that by chance, my first job with Professor David Barlow, he headed the IVF unit in Oxford. And so immediately as an SHO, I was introduced to IVF and fertility clinics, and I just fell in love with that. I enjoy looking after obviously women and men having problems. I like looking after them for maybe a few years and seeing their journey through. And I love the science and the ethical side of what we do within infertility. Then I thought, well, I want to go abroad somewhere to do my doctorate research and get out of the UK. And I thought, well, Canada's a good place to go to. There's obviously been long links with the UK and Canada. And I also like France. I like speaking French. And I thought, well, I'll go to Montreal in Canada because there I'd have to speak French every day to patients, which I did. And Professor S.L. Tan was there at the time when I was there at McGill in Montreal. And at the time, this is late 90s, Montreal was one of the two main centers in the world that were researching oocyte IVM. And so I got into researching that, did my doctorate in that, published a lot of papers, came back to the UK and got my consultant job, and then introduced IVM into the UK. So that's it.
Wonderful. I'm sure all of us who are listening to your journey today get some kind of, enlightenment how a journey can be thought of and what are the steps. So you served, and I remember that time I was there. So you served as the director and medical director of the Oxford Fertility Unit from 2004 to 2023, but you also did a very fantastic project of co-founding the fertility partnership, scaling it
Mhm.
to 20 clinics across 6 countries. And
Mhm.
what were the key challenges and lessons in building such a large assisted conception network? I'm sure this is something a lot of leaders and achievers and people who are having this enterprising spirit like you would be willing to know.
Yeah, it's interesting. So within UK medicine, again, I know it's different in India, but within UK medicine, IVF and fertility has always been pushed outside of the NHS to a degree. So it's always been quite um, a commercialized, but also it's inviting an entrepreneurial spirit into it as well. Because in the UK, most patients see NHS doctors, they're in NHS hospitals, private healthcare is quite a small bit. But IVF, the majority is within the private healthcare setting. And that was one of the things that attracted me to it. Working alongside the NHS and the university was just the ability to to make budgets. If there's extra money that comes in, you can reinvest it. The money's not disappearing off somewhere else into the healthcare system. So that's one of the things that attracted me into the IVF space. So then in 2011, myself and a colleague, we decided we should merge our clinic in Oxford together with a clinic in London at the Hammersmith Hospital. And that was really the start of the fertility partnership, which is TFP. And we then grew it, as you said, to 21 clinics, laboratories over 6 European countries. Now, in terms of the chat, I learned so much. I mean, I didn't go to business school, and you pick things up as you go along, but all of a sudden you're dealing with people who all they do is business, and they've come from a very cutthroat background. I think they also, some of these people would look at doctors as being financially naive, which is probably quite true for, for most of us. And so I think one of the things I learned very early on was just, a very trusting person, but just be very careful. And, you know, contracts, legal contracts, get them checked over by an independent lawyer, because we had things where we signed things and then the business people we were working with were like, well, you should have read the small print. You should have been a bit more careful with that. So I think one thing I learned was, it's really good working with business people because they bring a different rigor to things than we bring to the table, but also just get things checked over. That's what those guys do. We should be doing it as well. Another thing is that when you're expanding clinics, or you're building new clinics, or you're having other clinics join your network, it's to try and do it as much as possible with like-minded people. So to work with other doctors in other clinics that think the same, roughly the same way as you about what's important in a business. That is, the patient care should come first, but generally the ethos, if it's similar, and that worked really well. And that's how we grew very quickly from 2 clinics to 10 clinics in the UK. Now, the big challenge started when we started going outside of the UK into continental Europe. So Germany, Denmark, Holland, Austria, and Poland, because obviously there's a different language. So there were language issues potentially. But the big difference was the medical culture was just very different. And so in some of the countries, the doctors really thought they were gods. I mean, it was a very difficult thing to deal with. They were very difficult for them to sort of change their view on things and maybe see patients as being more important. So we had a struggle sometimes with differences in medical culture. But overall, I loved the experience. I was there from one clinic up to 20 clinics. I like the people I work with. I like travel, so I really enjoyed the different clinics we went to, meeting different people who worked there. I still keep in touch with lots of them. But at the end, October 2023, I thought, okay, now it's time for me to move on and do something different.
I really appreciate that you're really being so candid about the journey and really with no guard you're sharing with our audience. So this is really priceless. So as the IVF clinician on the NICE's fertility guidelines development group, what were the most contentious or surprising debates, and how did evidence inform the final recommendations, I would say?
Yeah, so I was involved. So there currently is work ongoing for the new NICE guidelines. I'm not involved with that because I'm on the HFEA board. It was felt it would be a conflict. So I was involved with the previous NICE guidelines, but the ones which are still currently in place. And so I'm sure most people listening to this have heard of NICE guidelines, but they may not know what it is. So what it is NICE, which is now the National Institute for Clinical and Health Excellence, was set up by the UK government to try and make sure that the NHS money was spent appropriately. So what happens is that the NICE guidelines in fertility, for example, look at not just outcomes of treatment, but also the cost of achieving that outcome. So, for example, guidelines that might come from the British Fertility Society or the European Society may just focus on clinically, does this drug improve the outcome? And they may not be interested that it costs £1 million or euros or whatever to achieve that. Whereas NICE looks at the clinical and cost effectiveness. So it's quite a big difference. Now, if the NICE guidelines come out and say that, yes, this is an appropriate treatment, it doesn't mean that all people in the UK will have access to that treatment. And this is an issue because NICE can make recommendations, but the individual NHS healthcare boards don't have to follow them. They have to consider them, but they don't have to absolutely follow them. And that has led to a problem because what sometimes happens is you can have the NICE guidelines might say that all NHS patients should have access to 3 IVF cycles. And women in one county their health board might agree to that, but their friends who live over the border 30 miles away, their health board may say, well, we don't have enough money for that. It's called the postcode lottery, so it does exist. But in answer to your question, in terms of contentious things, when we were asked to do it, we were given different topics, and I was asked by the Department of Health to focus on ovarian reserve markers and predictors of outcome. And I think it was because the thinking was that a woman could have an anti-Müllerian hormone blood test, an AMH blood test, and maybe that could predict her chance of IVF. And therefore, that AMH blood test could predict whether or not the NHS should fund her IVF. Because at the time, the government were keen to move away from age-based treatment towards something independent of age, because they were being accused of being ageist, and at what age should you stop doing treatment? But unsurprisingly, and I said this very early on, well, AMH, of course, is not going to predict outcome very well, because if you have a 44-year-old woman with a good AMH, the problem is her eggs are 44 years old. That's going to be the more important thing, not her anti-Müllerian hormone, which is a measure of ovarian reserve. So that was quite contentious. So there was a lot of politics. Again, it was interesting to see how these national bodies work. There's quite a lot of politics got involved about at what age do we stop, or do we suggest that IVF treatment stops, because we were being accused of rationing based on age. And so government got involved at that stage. Something which we didn't look at closely enough, but which is being looked at more closely now, is male fertility. So when we did the NICE guidelines, we were given a scope of what to look at. And male fertility was only a small part of the scope at the time. So certainly, I can see now that there wasn't enough work done on perhaps the effect, varicocele effects on fertility and sperm DNA fragmentation testing, which was just coming in at that time. Now, I know that the NICE guidelines now have got much more of a urologist, andrologist input into them to try and redress that balance.
Yeah, it's also very exciting to see how even organizations think differently. So, because their goals are set with the different, the parameters that they are being judged are different sometimes. So your journey is truly very enriching. So HFEA, which is we are all regulated by this central body, and it's a matter of huge proud for us all that it's such an old organization, and many countries still don't have anything close to that. So HFEA's Scientific and Clinical Advances Advisory Committee, which you chair, introduced the IVF add-ons traffic light system. So can you explain that framework, how this framework was designed and to benefit the patients, of course, and what improvements you'd like to see going forward? What's the near future looking like?
Yeah, well, the HFEA is interesting. So I can honestly say, if anyone has the chance to get involved, you have to be older than you are, Anu. You're too young, I'm afraid. You have to be old like me to probably get involved in it. But if anyone has a chance to get involved with something like the HFEA or NICE or whatever fertility society it is at a senior level, do it. I mean, for the HFEA, for me, I really enjoyed the 3 years I spent on NICE. I loved, and it really, I found it very interesting. I made some amazing connections with people. The HFEA has just been like that times 100. It's been one of the highlights of my career. I applied to join the HFEA as a member back in COVID times, I think 2020, 2021. And then you go through quite a rigorous interview process. You're then appointed to it by number 10 Downing Street, and then it's a 3-year position. They can continue it for another 3 years. So I'm in my second 3-year term. The committee, the main HFEA committee, is just full of people who've done all sorts of different things. The minority are clinicians. So by law, the majority have to not be people working within the professional sector. So we have people on there who are stem cell scientists. We have an ex-bishop on there, the Bishop of Norwich. We have all sorts of different people on there. And then the HFEA, which regulates fertility treatments and research in the UK, has a number of subcommittees. So as you say, I chair the largest subcommittee on the HFEA, which is a Scientific and Clinical Advances Advisory Committee, which is SCAC. We have about 20 members on there. We've just interviewed for new members in AI expertise and also male fertility andrology as well, because we have again a 6-year rolling, you're in, then you're out 6 years later. So what we do is we look at what's coming over the horizon. So we look to see what things are out there that are coming into reproductive medicine that the government really should get a hold of and regulate. And that's our main role. We're also responsible, as you said, Anu, for the add-ons traffic light system. So this was brought in before my time. This was brought in by my predecessor in about 2017. And it was in response to, and people may not know what an add-on is. So you have a standard IVF cycle. An add-on is normally an intervention that can be added onto it, usually for an extra cost. And usually there's very little evidence of any benefit of these add-ons, but they nearly always cost extra. And it's very commonly offered to patients who obviously are often desperate and will say yes to anything. So the government asked the HFEA to bring in some sort of system for helping give information to patients about add-ons. And the first one that came in 2017 was a very simple traffic light system. It was red, green, or amber. So red means don't use it, green means use it, amber means studies are conflicting. The problem was nearly all of the add-ons were amber because either studies hadn't been done, so no one knew at all, or studies had been done and were poor quality, or studies had been done and one said yes and one said no, so they balanced out. So about 3 years ago, I was asked by the chair of the HFEA to try and improve the add-on system. So we went out to the sector in the UK, went out to patients and also professionals saying, well, how could it be improved? Should we have more different outcomes? So rather than just 3, have 5, which is what we moved towards. Should we also use studies, not just randomized controlled trials, but should we also use cohort studies if there are no RCTs? And should we use different outcomes? So rather than does this outcome increase the live birth, which is obviously important, how about other outcomes? Does this add-on reduce the miscarriage rate? Does it reduce the time to live birth? Does it reduce the risk of OHSS? So these are all things that we brought in to it. And then about a year and a half ago, we went through all of the add-ons and we reanalyzed all the data by committee, and then we reallocated different outcomes. But we're now, and our next meeting in October, we're looking at sperm DNA fragmentation as an add-on, uterine microbiome, lots of things like that that are a PRP, platelet-rich plasma, which is used in some clinics, some countries. So that these are all things which are going to be graded as add-ons.
Yeah, so I would say we actually always have our eyes on that page of the website. So you've published 100 research papers and introduced new fertility techniques in the UK. Could you share one innovation that excites you the most and what next is on the horizon in ART?
Well, I mean, the thing that excited me the most was when I was very involved in it was IVM, oocyte IVM. And that's why I went to Canada. And so I came back and then we spent, myself and my lead embryologist in Oxford, we spent 4 years trying to persuade the HFEA to allow us to offer oocyte IVM. We went to some of the best units in the world to look to see what they were doing with it. And then we introduced it. And the first patient that we treated was an Indian woman actually whose parents had relocated to the UK when she was very small. So Indian woman married to a Caucasian British guy. She had PCOS. She was the first patient that we treated. We put 2 day 3 embryos back because embryo quality was not great, and she had twins. And the twins amazingly live 5 doors down from my house here in Oxford, and they are 17 now. And I've been to all of their birthday parties. So I see them all of the time. And so that's that. So for me, that's been one of the highlights for me because it's just a reminder. Now, IVM is not used so much now because people have moved on to different types of IVF protocols. So there's really not, I don't think, a need for IVM now, but that was an amazing time to be there. In terms of what's coming over the horizon, I think from a patient treatment perspective, I mean, AI is obviously of interest, but at the moment, I don't think there's been any advances really that have used AI. If anyone goes to any of the big fertility meetings, the big conferences, then the different manufacturers are saying, "Oh well, this AI algorithm will help you choose which embryo to go back from the time-lapse incubators." But none of them have been shown to increase the live birth rate, and there's no data at all, which is why AI within time-lapse incubators in IVF it's rated black on the HFEA add-on system because it's been proven to not increase the live birth rate. It doesn't do harm, but it doesn't increase the live birth rate. So I think AI obviously has a lot of promise and things will come, but we're not there yet. But the thing that will come, and it will make a massive difference, will be in vitro derived gametes, so IVGs. So there's a lot of money being pumped into this around the world because there's a lot of money to be made from doing this. And what will happen will be it's happened in mice already. What happens is you take a skin cell or a blood cell, you then reprogram it into a different type of cell, and you can reprogram it into an egg or a sperm. You can even take a skin cell from an XY man, and you can reprogram the X into an egg and the Y into a sperm. You can make eggs and sperm, and this has been done in mice, from a male. Now, the reason there's a lot of money going into this, and there are companies in the States and also in Japan that are very focused on this, is because what it would mean would be you could have a woman aged 46, where really her own natural fertility has pretty much gone, but she could give a blood test or a skin swab, and she could make limitless numbers of eggs that have not been affected by aging the same as eggs that she was born with in her ovaries. Women with premature ovarian failure, men with azoospermia, where sperm can't be found on testicular biopsy. A woman can make 1,000 eggs, therefore you don't need to go through IVF cycles. So the opportunities are limitless. But the big thing is, how safe is it? Because just because you can make an egg from a skin cell that looks like an egg, or a sperm that looks like a sperm, does not mean that it's as safe in terms of long-term health of any baby born and epigenetics. Doesn't mean it's as safe as a real egg or a real sperm. And so this is something that from an HFEA perspective, we've discussed, should this be allowed? Because the scientists are really pushing. They're saying, some of them are saying within 3 to 5 years, we will be able to make eggs in the laboratory, limitless eggs. So this is not science fiction. This is potentially happening soon. The problem is, should it be allowed? Do you want to be the first person to have an embryo, put into your uterus that's been made from an artificial or in vitro derived egg or sperm? Will that baby, if born, be okay at birth, age 10, age 20, age 50? With epigenetics, lots of these diseases happen later on in life. And that we just don't understand that side of things so far. So the recommendation that we made from an HFEA perspective was that the research should be encouraged, but that it should not be allowed to put any embryos into a woman that have been made from IVGs. And that was our recommendation to the government for consideration of how to regulate IVGs. But it's a very exciting area.
Absolutely. So there's a lot of ethical perspective to it, but very
Yeah.
exciting. Maybe the whole way of treatment in the older women would look very different in future if it
Or
is
even
successful.
younger women, because if you
Nobody
were
wants to go through. Yeah,
no one wants to go through IVF and get 10 to 15 eggs collected. If you can give a blood test and have
true.
1,000 eggs, why do you need?
Yeah.
But the other thing is, say, I don't know, so Beyonce walks past you in the street, and you pull a thread, you pull a bit of a hair out.
Oh,
You could make
yes.
Beyonce eggs. Who owns them? Where's the ethics in all this? So where's the consent process? So you essentially you could make limitless eggs from movie stars, from Nobel Prize winners.
Yeah.
Ethically, it's a very challenging area, but very interesting.
Yeah. Maybe we'll all have to retrain in IVF or fertility practice
Yeah.
then. So in 2021, you were appointed to the HFEA board by the Secretary of State for Health. And what are the most pressing regulatory and ethical challenges you're tackling now at the national level?
Yeah, so we've had because the government the HFEA asked us to suggest to them areas of regulatory change, because the HFEA as a body is there to make sure that people in clinics follow the law. The law is set by Parliament, but the law is actually quite out of date. It's actually from 1990, so it's a really old law. It's been changed a bit over the years, but the government realized they need to have a complete redo of the law to include, surrogacy, different family models, because the law was written around married couples. That's what it was focused on. Yeah, a male and female married couple. So the law is very out of date. So we had a lot of discussion over the last 1 to 2 years within the HFEA about areas that we felt the government should look at to regulate. So I've already mentioned one of them, which is in vitro derived gametes, or IVGs. There's also embryo research. So at the moment, pretty much around the world, scientists are only allowed to study embryos up to 14 days of development. It's called the 14-day rule, and it came in from the HFEA back in 1990. And most governments around the world have just followed the HFEA lead on that.
Yeah.
Now, what scientists are saying is that the problem with only being able to research embryos up to 14 days is that there's then a big black box and unknown what happens to embryo development beyond 14 days, because at that point there's all sorts of other, obviously, very rapid developmental things happening in a very early fetus that we have no knowledge of. We can get pregnancy termination or abortion tissue, but that's probably from 6 weeks. So there's a missing 2 weeks there where we just don't know what happens. So we recommended to the government that with appropriate ethical research consent on a case-by-case basis, that scientists should be able to research beyond 14 days up to 28 days of embryo development in a laboratory. But at around 28 days of embryo development, you are starting to see development of heart activity. So again, it's something that from a public point of view, at some point the public might say, well, we don't mind people with ethical consent researching on embryos that just look like a mass of cells in a lab. But at what point does the public start thinking, but hold on, I know it's still cells in a lab, but it's looking more and more fetus-like. So that's something else that we discussed with the government. And then the final thing to say, other things would be surrogacy reform. So in the UK, and I know in India, I think surrogacy has been banned now, I think in India, but so in the UK it is allowed, but it's done in a very the law is very out of date. So it has to be done in an altruistic way, but surrogates can be paid expenses for it, but the expenses vary. And then the baby, when it's born, actually the woman, the surrogate who delivers the baby, is the legal mother. So the intended parents have to actually get parental orders in place to actually have the baby legally theirs. In the States, it's very, very different. And so what we ask for is just a relook at surrogacy laws just to make them more fit for purpose.
Yeah, I think patients are looking at that a lot. A lot of patients who are waiting for the clear guidance, who have to look at other options, will be very happy with this. In 2021, you received the European Fertility Society's Lifetime Achievement Award. Congratulations. Looking back, what accomplishment are you most proud of in the career so far? I guess it would be trying to do IVM, because that is the beauty of the scientific culture of UK and Oxford, that you try with all honesty. We don't know the outcome, but I would want to know if there's anything more. Yeah.
Well, I think from an IVM perspective, we got up to about, I mean, at our busiest, which is probably about with IVM, which is probably about 12 years ago, we were doing about 200 IVM cycles a year and about 1,200 IVF. So it was a minority, but it was still quite a lot. I mean, now there's just none being done at all. So I was very proud of the IVM work that I was involved in as part of a team, and the embryologists obviously were the most important part of that, because I did the easy bit, they did the difficult bit in the lab. I think the thing I'm most proud of probably is the MSc. So the MSc in clinical embryology that I co-founded back in 2008 has had, I think, more than 300 alumni come through, most of them from outside of the UK, so worldwide alumni. And I love sort of keeping in touch with those people, and they've all done really well to get onto the MSc, and then unsurprisingly, they've done very well afterwards, academically or business-wise or embryology-wise around the world. So I'm very proud of that. And I guess most of all, the team that I was involved in building in Oxford and more widely with TFP worked with a great bunch of people, some of them for over 30 years, and working with them and helping each other as well. I mean, it's not a one-way thing, so we help each other. We've helped each other over the years. So I think being part of that has been I've been very proud of that.
Yeah. You're also a trustee of the Fertility Alliance. Now, this group campaigns for patient education and equity. Where do you see the biggest gaps in fertility knowledge and access, and how is this alliance addressing these?
Yeah, so the Fertility Alliance is a relatively new fertility charity founded about a year ago. So I was invited to be chair of the trustees on that. The two main people running the charity I've known for a long time. They've been patient advocates for 20, 30 years. So I've known them for a long time in the sector. And we have an amazing board of advisors and people involved with it. Um, well, there's two main things. I think one thing is campaigning for greater funding. As I mentioned, the NICE guidelines are adhered to in some places, but most health boards either ignore them for fertility or just do a very small amount of funding. So we're campaigning for fair funding across the board. And then secondly, from a patient education perspective, then there's so much misinformation out there that we are really trying to make sure that we run lots of webinars and podcasts and drop-in sessions for patients as well. Also clinic education. So the team go out to clinics and work with them to help improve the quality of patient literature that patients are given to explain treatment, online or on paper. But we've only been going for a year, so it's still quite early days at the moment. As with any organization, the funding is always difficult because in the end, I don't take any funding from it, obviously, but there are two people who mainly run it who have been working for free or very little over the last year. So it's difficult to run these small charities on hardly anything.
Yeah, so now we are moving closer to the closer of the program, but I'll have two more questions to go quickly. How do you balance exciting new fertility add-ons and technologies with the need to be evidence-based and avoid the hype? Especially given the abundance of information, I would point to the social media here. There's no cap, there's no regulation. People can put content on the social media, and generally it is targeted and talked about the add-ons. They don't even know they're falling under the category of add-ons. So what do you have to say about that?
It's very difficult. I mean, I think the HFEA website is very good because obviously it's not commercially linked at all. It's completely independent. So I think on there, I mean, my view is add-ons should be allowed. I mean, I don't think that just because something doesn't have evidence behind it doesn't mean it should not be used. But the patient should be fully aware of the lack of evidence. And I think often I see patients who've been told, do this, pay us £2,000 for it. And then the patients come and say, well, I've been told it will increase the chance of having a baby. And I think, well, that's not actually true. In fact, that's a lie. And obviously trying to deal or manage with that is difficult. So I'm all for I'm all for innovation. Absolutely. It's really important that innovation is there. But if things are coming in, then they need to be properly researched and shown before they are marketed. A perfect example is the ERA test, the endometrial receptivity
Oh,
assay,
yes.
which came in, it was marketed very heavily, sold to lots of patients. Then the study came out saying no benefit. And then another study came out saying it made your success rate worse if you use it. Now that was the cart before the horse. So again, we need to balance innovation with also responsibility of being fair and honest to our patients.
Absolutely true. I think that this is a very good example you've quoted. So you're active on Instagram and you host Q&As for fertility and miscarriage communities as well. So what is directly with the public and on social media, and how has that influenced your communication as a clinician and as an educator? And you can also share your handles details here.
Yeah, well, I mean, it's interesting. So it was about a year and a half ago, after I left TFP, I had a bit of time on my hands. And I've never really done a lot of social media stuff, but I started looking through Instagram. I didn't even have an Instagram account. And I saw such rubbish on Instagram, much of it put out by influencers who had no clinical background at all, but who had followings of 10,000, 100,000, 500,000, 2 million people.
Yeah.
And we're just saying stuff that was wrong. And then normally when you swiped through it, you realize somewhere they were selling something. So nearly always somewhere when you went through, bam, 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 they were selling either their time or a product, either their product or a product they got commissioned from. So I just thought, well, hold on, I'm not linked to a clinic because I wasn't linked to a clinic. I'm on the HFEA. I work in the University of Oxford. So I've got a number of things there that show that I'm independent. So I've just started doing some Instagram lives. I just put the phone there, press play, and then I say to people, ask questions. And any question they want. If I don't know the answer, I say I don't know. But if I do know the answer, and obviously it's not directly to them, it's a general question. You've got to be careful. You can't give direct medical advice to people you've never met before, but it's general advice on implantation failure or miscarriage or whatever it might be. And I keep it very evidence-based. And so, yeah, the handle is Dr. Tim Child, so DrTimChild. And I enjoy it. It doesn't take up much of my time. I get positive feedback from patients and people. I don't think it's really changed my practice because I think I was practicing like that anyway. I'm not someone who is so evidence-based that I will, with some people I think are probably over the top evidence-based. If there's no RCT, then they would not even consider something. Well, that's not really helpful for our patients because patients also want to feel as though they're not a number, that they are having a discussion with you. But then it's the responsibility of the doctor to say, okay, we can look at this, but we just need to be careful of the risks and the benefits. I mean, I've never prescribed IVIG, for example. I don't prescribe steroids. There's lots of stuff I don't do where I think the risks are there. Yeah, so
That's how we remember you, a lot of us who know you a little bit more.
yeah, so I'm doing a picture on the wall there. I do lots of car racing, so historic
Yeah.
Formula One cars from the early 1960s is what I race in Europe generally. And then I have a band as well. And we're doing two gigs this weekend. I play guitar and sing in a band. I think you're a singer as well, Anu, aren't you?
Yes,
Singer, yes, I remember.
I do. Yeah.
I remember.
Thank you for
Yeah,
remembering
so
that.
I
It's a
do. Well,
pleasant surprise.
maybe we should have a duet at say at a fertility conference in India at some
Oh,
point,
yes.
perhaps.
I think I'll ask the next organizers to invite you and then we'll do something. Yeah. So
Oh,
thank
I'd
you
love
so
to.
much.
I would love to get back over to India. I love traveling to India. I visited there from the age of 18, the first time I went backpacking my way around, and I've been back a number of times since. So I'd be more than happy to come back over.
Thank you so much for taking time to join. And I'm sure all the audience who took time to join us, you all had a great time understanding how an achiever like Dr. Tim Child thinks and shared his journey. So thank you, Dr. Child.
Thank you, Anu. Thank you. Bye bye.
Thank you. Bye-bye.